Hello everyone, welcome back to the channel. In today's video, we are going to cover heart failure, pathophysiology and diagnosis. This is a high yield topic for both examining and clinical practice, so stay tuned till the end. Definition and basics. Heart failure is a clinical syndrome occurs when structural or functional heart abnormalities impair the ability of ventricle to fill or eject blood. Universal definition requires two things: symptoms or signs of heart failure like breathlessness, fatigue, or edema, objective evidence of cardiac abnormality, either elevated natriuretic peptides or objective evidence of pulmonary systemic congestion. So, symptoms or plus objective evidence equal to heart failure. Types of heart failure: classify heart failure based on ejection fraction. Heart failure to reduce ejection fraction less than 40 or 40. Heart failure with mildly reduced ejection fraction, that is ejection fraction 41 to 49%. Heart failure with preserved ejection fraction, that is 50 or more. Heart failure with recovered ejection fraction. Recovered means when ejection fraction improves after therapy. Heart failure with reduced ejection fraction is ischemic heart disease and dilated cardiomyopathy are common causes, where the heart failure with preserved ejection fraction, hypertension, diabetes and obesity are common causes. Most patients, regardless of the ejection fraction, have abnormalities in both systolic and diastolic function. Pathophysiology: heart failure usually starts with an index event like myocardial infarction or long-standing hypertension. This sets of structural and functional changes known as ventricular remodeling. What is remodeling of the ventricle? What happens? Myocyte hypertrophy, fibrosis, ventricular dilatation, and systolic or diastolic dysfunction. These are the four important components of the ventricular remodeling. Reduced cardiac output activates what? The sympathetic nervous system, increasing heart rate and contractility. Number two, renin, angiotensin, aldosterone system, RAS, causing sodium and water retention, vasoconstriction, and fibrosis. Number three, vasopressin secretion, worsening fluid overload. These three components are getting activated when the cardiac output is reduced due to heart failure with reduced ejection fraction. What happened? Initially compensatory, these three are causing compensatory action, but these responses ultimately worsen the heart failure by causing volume overload, arrhythmia, and cardiac remodeling. Causes and risk factors: coronary artery disease and MI, hypertension, valvular heart disease, myocarditis or cardiomyopathy, metabolic conditions like diabetes, thyroid disorders, and obesity. Clinical features: congestion related dyspnea, orthopnea, paroxysmal nocturnal dyspnea, edema, ascites. Low output related fatigue, weakness, confusion, cold extremities. The NIH functional classification of heart failure: Class 1, no limitation. Class 2, slight limitation. Symptoms with ordinary activity. Class 3, marked limitation. Symptom with minimal activity. Class 4, symptoms at rest. Examination and diagnosis: elevated jugular venous pressure, S3 gallop, pulmonary rales, peripheral edema, ascites, and hepatomegaly. Diagnosis is supported by BNP or NT-proBNP, echocardiography, the gold standard for ejection fraction assessment, ECG and chest X-ray. Conclusion: heart failure is a syndrome, not a single disease. It results from structural or functional heart abnormalities, leads to neurohormonal activation, and carries a high mortality if not treated early. Recognition and guideline directed therapy improves the survival. Mortality: the 5-year mortality after diagnosis is close to 50%. So early diagnosis is very important. Thank you for watching.